Hello guys, welcome to Pharmacological channel again. Today I'm going to talk about pharmacology of fibrinolytics. As we know that normally our body will have endogenous fibrinolysis system, and the name will tell the story, right? Fibrinolysis means you lyse or you degrade fibrin. So once the clot occur in the blood vessel and it causes a slower blood flow, this leads to the activation of endothelial cells to secrete the tissue plasminogen activator, and tissue plasminogen activator will bind on fibrin, on the clot, as well as the plasminogen. It has a binding site for fibrin. So these two proteins have to bind on fibrin, and then tissue plasminogen activator will convert plasminogen into plasmin, and plasmin will act as an enzyme to degrade fibrin. So the clot will be degraded like this. However, in normal physiologic condition, there is a balance between fibrinolysis and its inhibitors. For example, there is a certain amount of plasminogen activator inhibitor, or PAI, particularly PAI1 in the plasma, and this PAI will inhibit tissue plasminogen activator. The alpha-2 antiplasmin in the plasma could also inhibit plasmin. So this is why in case of hypercoagulable state, or in case of overactivation or overstimulation of the platelet aggregation and coagulation cascade, the normal physiologic fibrinolysis system could not fight against these overactivated state of clot formation. So we need the drug that are more potent and resistant to the inhibitor in order to fight against these pathologic condition. So the fibrinolytics, sometimes called thrombolytics, and it's straightforward. These drugs will lyse or degrade a thrombus. There are two main types of fibrinolytics, including indirect acting and direct acting. The indirect acting, for example, the streptokinase. For the direct acting, generally they are a recombinant human tissue plasminogen activator, and the name will be like Tplase for all of them, such as Altiplase, Tenecteplase, and Reteplase. For the streptokinase that act as an indirect acting fibrinolytics, this drug initially derived from the beta hemolytic streptococci bacteria, and the function of streptokinase is it forms a complex with plasminogen in the blood to become plasminogen activator complex. And once this complex binds with fibrin on the clot, the streptokinase will convert plasminogen into plasmin, so become plasmin streptokinase complex, and this plasmin will further convert the plasminogen on fibrin into a plasmin. Then plasmin will degrade fibrin to become a degradation product to lyse the clot. This is why we call streptokinase as indirect fibrinolytics, because it needs to form an activator complex first before changing plasminogen into plasmin to degrade fibrin. The next one is recombinant human tissue plasminogen activator. As I mentioned, these drugs become more resistant to the inhibitors such as alpha-2 antiplasmin or PAI1. For the recombinant tissue plasminogen activator, the mechanism of action is similar to the endogenous tissue plasminogen activator by binding on fibrin and convert plasminogen on fibrin to become a plasmin, and then plasmin will cleave or cut fibrin into a degradation product. So this group of drugs are a direct acting, and it is a fibrin specific because it needs to bind with fibrin. Both of them, the recombinant tissue plasminogen activator and also plasminogen. For urokinase, it is a human-derived enzyme found in the kidney and sometimes is excreted through the urine. Urokinase is also acts in a similar way as the tissue plasminogen activator, so it is considered as a direct acting fibrinolytics as well to lyse the clot. And these drugs, they are mainly used in an acute setting. Since they are all the injectable form, they need to be administered through an intravenous injection or infusion, depending on the properties of the drug. For the streptokinase, it is indirect acting, as I mentioned, and it is non-specific to fibrin, since streptokinase and plasminogen complex at the beginning could bind with plasminogen or other protein in the plasma, so it may lead to adverse consequences due to a non-specific fibrin binding. Streptokinase can also cause hypersensitivity reaction, and the antibody to streptokinase could be elevated following 3 to 5 days of administration, and this antibody will persist at this high level for like 1 to 4 years. So during this period, the patients could not use streptokinase until the antibody level will decrease and undetectable. So the indication of streptokinase could be in acute Curie syndrome that could not undergo a percutaneous coronary intervention, PCI, so they need the fibrinolytics or thrombolytics to lyse the clot. And also in some case of pulmonary embolism. But streptokinase is contraindicated in acute ischemic stroke, since streptokinase increases the risk of intracranial hemorrhage and death due to this cause. So it is contraindicated in acute ischemic stroke. For alteplase and other recombinant tissue plasminogen activator, they are all direct acting and specifically bind on fibrin, so it may have a less adverse drug reaction than streptokinase. The difference between these recombinant tissue plasminogen activator is a half-life. For alteplase, it has a very short half-life, less than 5 minutes, so it needs infusion, like intravenous infusion, whereas tenecteplase and reteplase may not need a infusion since it has a longer half-life. We could administer like an IV bolus. And these recombinant tissue plasminogen activator do not cause hypersensitivity since its structure is similar to endogenous tissue plasminogen activator, whereas streptokinase is derived from bacteria, so it might cause like act as an antigen to produce an antibody against itself. The indication of altiplase could be in acute coronary syndrome, who could not undergo PCI, in acute ischemic stroke. So patients need thrombolytics to lyse the clot in the cerebral vessels, and also some massive pulmonary embolism, or in case of central venous catheter occlusion. For its native place, it could be used in acute coronary syndrome in patients who couldn't undergo PCI, and also in ischemic stroke, but not in the venous thrombosis. For retiplase, it could be used in acute coronary syndrome in patients that could not undergo PCI. This is the summary of the properties of the fibrinolytics. And thank you for watching this video. I hope you enjoy the lesson from Pharmacology, and please subscribe and like the channel, and see you in the next video. Thank you very much. Bye.